Hello, and welcome to the Liver Cancer webinar. This is Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us. Liver Health Foundation is a patient advocacy 501c3 nonprofit organization representing millions of liver patients in California and beyond. Tonight's webinar is about liver cancer. As you may know, October is the National Liver Awareness as well as Liver Cancer Awareness Month to raise awareness of liver and its importance in our well-being. There are more than 100 different liver diseases caused by viruses, genetics, autoimmune disease, excessive alcohol use, poor diet, obesity, reaction to medications, street drugs, and toxic chemicals. Liver cancer was once mostly seen in older adults and patients with hepatitis, but it is now seen in younger patients and those without hepatitis. Today, liver cancer stands apart from all other liver diseases since it is one of the few cancers that is on the rise in the US due to a poor lifestyle causing obesity, diabetes, high cholesterol, and high blood pressure. While many researchers, physicians, and pharmaceutical companies are working to develop better and more reliable treatments to prevent and to treat liver cancer, there are still many liver patients who die of liver cancer while waiting for liver transplantation. It is estimated that every year over 30,000 people die of liver cancer. In tonight's program, we will hear from some of the best liver cancer specialists and hepatologists about this disease, as well as the advances that have been made in medical research. Now, I have to put our disclaimer in so we don't get in trouble. Please remember, information given by our experts is not a substitute for advice given by your own physician or healthcare provider. We do not endorse hospitals, medical groups, treatments, or doctors. So please consult your own physician. All right, it is now my pleasure to introduce Dr. David Imagawa, who has generously accepted to be the presenter and the host of our roundtable section of this program. David K. Imagawa, MD, PhD, is the Susan Dacoma Endowed Chair in Pancreatic Cancer, Chief Division of Hepatobiliary and Pancreas Surgery, Professor of Clinical Surgery, Vice Chairman for Academic Affairs, Department of Surgery, University of California, Irvine, which we lovingly know as UCI. Dr. Imagawa's clinical and research focus is the treatment of liver, pancreas, bile duct, and gallbladder cancers. He is also an expert in the prevention and the treatment of bile duct injuries during removal of gallbladder. He has been involved as principal or co-investigator in over 120 clinical trials. He has over 130 articles published in peer-reviewed journals and is the author of numerous book chapters and abstracts. Dr. Imagawa currently serves as an ad hoc reviewer for Transplantation, World Journal of Surgery, Liver Transplantation, American Journal of Transplantation, HPB Surgery, and Archives of Surgery. He is a member of many professional and medical associations, including the Association of Academic Surgeons, the American Society of Transplant Surgeons, the American Hepatopancreatobiliary Association, the Pacific Coast Surgical Society, and a fellow of the American College of Surgeons. He is also actively involved in service to the community and presently participates as a member of the Liver Health Foundation's Medical Advisory Council and also assists the Pancreatic Cancer Action Network with their yearly fundraiser. Dr. Imagawa received Liver Health Foundation's Lifetime Achievement Award in 2022. We are excited to have Dr. Imagawa share his knowledge and expertise in liver disease with our audience. Dr. Imagawa, welcome, and thank you for your support and participation. We are ready for your presentation.
All right, can you hear me there? Let's see.
Yes.
Okay, great. Well, welcome everybody. And Farah, thank you for that very nice introduction. And I know you'll introduce my co-panelists later, but welcome Dr. Singh, Dr. Khan. We look forward to your comments and information. I'm going to kind of open things up by giving you a brief overview of liver cancer. It's a kind of a rapid fire technique, if you will, since we have a fairly short period of time. And then we have a bunch of really great and compelling questions that the audience has already sent in. And I think there's room, if you go to the chat room, to send in additional questions as we go through the talk. As Farah alluded to, liver cancer is really becoming a major health problem in the United States and is already a major health problem within the world. And as you can see, in 2020, which is the last year we have actual numbers for, there were 38,000 deaths and cases in the United States, with most of them unfortunately leading to death. 800,000 cases in the world, with an estimate of, I think, of 1 million this year. And it's the fastest rising death rate of all cancers. Risk factors, I think, as everybody remembers, are alcoholic liver disease, and then the viral hepatitis, hepatitis B, and hepatitis C. And of course, now what's coming to the forefront, non-alcoholic steatohepatitis or non-alcoholic fatty liver disease. Unfortunately, the disease of the liver attributable largely to the current lifestyles that most of us live. So when we have liver tumors, and primary liver cancer is what we're going to work with today. There are several surgical techniques that we can use to take care of them. The liver is divided into basically 8 different lobes, and we can isolate 8 different segments and 2 different lobes, and we can do surgical resections to remove very large portions of the liver. We can do surgical resections to remove smaller portions of the liver, such as non-anatomic resections or segmentectomies. We can do liver transplants, and that's a whole nother story into itself. And I know that every year Farah brings the liver transplant experts here to talk about the indications for liver transplantation. We can do things called ablation. There's radio frequency ablation and microwave ablation, where basically tumors use either high energy from microwaves or high electrical impulses to kill the tumors. And then we can do things, even very simple things for small tumors, of injecting absolute alcohol into them. And this is a very popular technique in Europe for tumors that are under 2 centimeters. We can also do something called chemoembolization, where chemotherapy or beads are injected through the artery that goes up into the liver and can deliver chemotherapy up to the tumors directly. We can do radioembolization, where similarly radioactive particles are injected into the hepatic artery and up into the liver. And lastly, we now have systemic chemotherapy, which has become very, very dominant in the area of liver cancer treatment, with numerous new drugs and protocols having developed over the recent years. So again, if we look forward at these treatments, surgical resection still has traditionally remained the gold standard, because this is the best way to remove the actual cancer. This is a large cancer, which we can see here in the right lobe of the liver. And this is from many years ago. And in those days, we did what we called open liver resection. So this is through a very big incision. This is looking down on the vena cava, which is the main blood vessel going up into the liver and running behind the liver. And then we could remove large segments of the liver with a big incision. And here's about an 8-centimeter tumor that's been removed through a relatively standard large incision 10, 15 years ago. We've made a lot of progress in that aspect, and even though the results have been very, very good, we can also, we can see that there are recurrence rates that occur over time. And so the big problem with liver resections in 2020 has been that once these tumors are removed, there's a very big and high propensity for these tumors to come back over time. The other thing that was a problem in the earlier days was this fairly significant operative mortality and morbidity associated with a big operative incision. Fast forward to 2023, and we're now doing these procedures laparoscopically. So it's like looking into a big video camera. And so we have a big tumor down here in the left lobe of the liver. This is an ultrasound machine that's helping us to show where the tumor is and where to mark it. And then we can basically use these instruments that basically are like long chopsticks, and we can insert them through little ports and do this essentially as a very, very sophisticated video game. And so then the incision that the patient receives after this type of surgery is basically only the size of what needs to be made to remove the tumor. So very, very big advances in the area of surgical technique. It shortens operative time, it shortens blood loss, and improves short and long-term survival by using these techniques. So what are the factors that affect the outcomes in liver cancer? And it's, I think, fairly simplistic in the sense that it's the size of the nodules, the number of the nodules. Are these tumors invading into the blood supply? Are the lymph nodes involved? And are these high-grade or low-grade tumors? The problem is that when patients come and are diagnosed, only 3 to 30% of patients actually have liver tumors that can be removed at the time of surgery. So this brings us to all of those other modalities that we have available. Radiofrequency ablation, again, which using molecular friction and heat, or microwave ablation, which uses basically the same kind of high oscillating megahertz electrical current that you use in your microwave oven to cook tumors and cook food. And this basically cooks tumors in the same fashion. This is kind of just what we show is how these things work. This is a liver that's from a calf that's just been shown that if you take the microwave or radiofrequency ablation, you can basically turn normal tissue into cooked dead tissue, and that's how these ablations work in humans. Here we see a small tumor, about 3 centimeters, located in the border of the right and left lobe of the liver. And when you've done with your ablation, you get what we call the black hole, where you can see that basically the tumor and a margin of surrounding tissue has basically been obliterated. For small tumors, this form of ablation is probably equal to liver resection. So for tumors that are 2 centimeters or less, patients live basically the same amount of time, whether you do a resection in red or an ablation in blue. But what I ask you to look at attention to is if you look at the time after surgery, by 5 years after surgery, almost 50% of these people have had their liver cancer come back and have died of their liver cancer. And this is one of the areas where, until very, very recently, we've made very, very little progress. Chemoembolization, as I talked about before, the liver tumors receive blood largely from the hepatic artery. So if you're able to inject agents directly into the hepatic artery and directly into the tumor, you, in theory, can get high concentrations of chemotherapy up into these tumors with less systemic side effects. And kind of just from a cartoon standpoint, if you will, you have a liver tumor up here, you have the liver, and you have these beads, either chemical coated beads or radioactive beads, and you basically have the radiologist introduce a catheter up into the liver tumor, and then you feed these beads or chemical agents directly up into the tumor. So the radioactive portion uses what's called TheraSphere or Certex. These are yttrium-coated glass microspheres. They're very, very small, about 25 microns in diameter. They emit a beta radiation, which is very intense, but very intense for a very, very short distance. So in other words, when these patients are treated, they don't need to be isolated. They don't need to be kept separate from the general population, and you're able to deliver fairly high doses of radiation directly into these tumors. And again, here's a very, very large tumor in the left lateral segment in a patient who is not a candidate for surgical resection. This patient underwent the radioactive embolization treatment, and the dark part means that the tumor is now dead. So you can see that probably over 90% of the tumor was killed by these radioactive glass beads. And these is not a curative process, but it helps to extend survival in patients who don't have resectable or transplantable liver tumors. And approximately, if you look again at 2 years, 24 months, about half the people have actually been able to survive fairly large, non-resectable liver tumors. What's the most exciting part, I think, about liver cancer in the last few years is the elucidation of the pathways and the mechanisms that go on within cancer cells to allow cancers to grow, or what goes on T cells that fight cancer cells and preventing them from killing off the cancer. And so this cartoon basically shows a cell surface of a liver tumor cell and these various receptors and the mutation percentages of these receptors in patients that have liver cancer. And so what the oncologists and the scientists have looked at is to target these specific receptors to try and keep cancer cells from growing. And this is the whole area of immunotherapy that the pharmaceutical companies have brought to the treatment of cancer, not only in liver, but in all types of cancers. Our first study was in 2006, which basically showed that a drug called sorafenib could improve survival. And again, these are your curves showing survival. And again, back then, we were happy if we saw people that 35, 40% of them could survive after 2 years. So we had made a small step forward, but the major steps and improvements in survival after chemotherapy have really happened in the last couple of years. And again, sorafenib was the first drug approved by the FDA in 2006, 2007, and it actually remained the only drug approved for liver cancer for a little over 10 years. Since then, we've had this remarkable progress forward. And one of the things that has been really exciting is this idea of what they're called checkpoint inhibitors, inhibitors that prevent or either prevent T cells from or help T cells in killing tumors, or prevent the cancers from hiding from these T cells. And so a lot of research, a lot of investigation has gone into this, and some remarkable forward progress has been made. And really the landmark study that's occurred was basically this combination of atezolizumab and bevacizumab, quite a mouthful. One of them is a vascular endothelial growth factor receptor inhibitor, bevacizumab, and the other one is a checkpoint inhibitor. And if you combine these two drugs together, you now see that when you start talking out a year's survival, about 70% of the patients are alive a year out. So significant progress when they compared it against the standard of care, which at that time was sorafenib. If we look at the longer data, which was just published, we can see that up to 3 months out, about 50% of patients are survival afterwards. Similarly, there's been another medication that's out there that looks at, again, the primer for T cells, which is CTLA-4. And this combination with a checkpoint inhibitor, again, shows very significant long-term improvements in survival. So we've made a lot of improvements over the last couple of years in terms of this. And I think it's very exciting times in terms of how we use these, the combinations of how we use these, and the combinations of how we may use these with surgery, ablation, embolization, or radioembolization. So, and again, to show you what's happened, the number of drugs that were approved last year for the treatment, or within the last 2 years for the treatment of hepatocellular carcinoma. So it's actually quite staggering the amount of progress that we've made, but it's also quite staggering how complicated things have become over the last several years. So lastly, I just show you an algorithm that tells us how we treat liver cancer. And this is the algorithm that was out there about 10 years ago, the BCLC criteria, the Barcelona Clinics for Liver Cancer. And it was a fairly simple thing. There was a certain number of patients that you could resect, a certain number of people you could transplant. And then unfortunately, the whole right side of this was best supportive care, some form of therapy, either systemic chemotherapy or chemoembolization. You fast forward now to today, and about 6 months ago, they redid this whole thing. And now you see this whole emphasis on the right side of the chart, looking at all of these combination therapies and all of these combination possibilities that were not available very short time ago. So again, these times are very, very exciting in terms of the progress that we are making. And it's very rewarding for someone who spent a long time in liver cancer to go from an era when we had no chemotherapy agents whatsoever to now having multiple agents that we can discuss at tumor boards with all of the specialists involved to try and find basically the best personalized, individualized cancer treatment for patients. So again, in summary, the small number of people that can get the ultimate is liver transplantation and surgical resection. But again, significant progress through the research that my colleagues have done in trying to treat these advanced stage liver cancers. I'm going to conclude there and invite my panelists to join me, and we will open this up for some questions.
Thank you so much, Dr. Imagawa. This was really eye-opening. I had no idea how many new medications have come and how much more research is being done. So that's really promising for those who are suffering from liver cancer. So at this point, we want to introduce our panelists. One of our panelists was Dr. Bayani from Torrance Medical Center. Unfortunately, he, just before we went on air, notified me that he had an emergency and he could not be with us. So now we are going to go and introduce Dr. Jeffrey Kahn. Dr. Kahn is a professor of clinical medicine and medical director of liver transplant program at Keck School of Medicine of USC. Dr. Kahn received his fellowship training in gastroenterology and transplant hepatology at the Keck School of Medicine and Cedars-Sinai Center in Los Angeles. He's board certified in internal medicine, gastroenterology, and transplant hepatology. Dr. Kahn's primary research interests are in liver transplantation, hepatocellular carcinoma, and viral hepatitis. He has written and co-authored several abstract and peer-reviewed articles on various topics such as chronic hepatitis C and liver transplantation. He is also a distinguished lecturer. I also need to mention that Dr. Kahn is a member of the Liver Health Foundation's Medical Advisory Council. On October 21st, 2023, just this last Saturday, Liver Health Foundation was proud to present Excellence in Healthcare Award to Dr. Kahn, along with Dr. Yuri Genek and Liver Transplant Institute at Keck Medicine, USC. Dr. Kahn, welcome back to our webinar. We appreciate your support.
No, it's a pleasure to be here, and I'm very happy to be here with Dr. Imagawa, who I've known for many years, and Dr. Singh. So looking forward to a vibrant discussion on liver cancer.
Yes. Now I will introduce Dr. Singh, and Dr. Jocelyn Singh is a health science clinical instructor at the University of California, Los Angeles, UCLA. Dr. Singh graduated from Washington University in St. Louis, after which she dedicated 1 year to City Year, which is an AmeriCrop program focused on tutoring and mentoring high school students in schools that have low graduation rates. After that, she graduated from the Ohio State University College of Medicine and completed her internal medicine residency and gastroenterology fellowship at Loyola University Medical Center. She finished her training in transplant hepatology at the University of Southern California, USC. Dr. Singh has been involved in clinical research in alcohol-related liver disease and hepatocellular carcinoma. She treats a spectrum of liver disease and cares for patients after liver transplantation. She's board certified in internal medicine and gastroenterology. Dr. Singh is a member of the Liver Health Foundation's Medical Advisory Council. Dr. Singh, welcome to our Ask Your Liver Doctor webinar. We appreciate you joining us.
Thank you for inviting me and happy to be here.
Thank you. Dr. Imagawa, will you please start the roundtable discussion?
Absolutely. And I guess if other folks out there have questions, please put them into the chat room and we will do our best to get to them. I'm going to throw the first question out to Dr. Singh. And someone asked, are there any symptoms for liver disease in addition to jaundice?
That's a great question. Often liver cancer does present without symptoms, which is why people who are considered to be higher risk for liver cancer should have regular tests done, such as with ultrasound, CT scan, or MRI. At times, people can have symptoms such as abdominal pain, general unwellness, fatigue, elevated liver tests, or elevated tumor markers. So these are all things that we, as liver doctors, watch out for regularly.
Great. Well, you kind of opened the door to the second question, so I'm going to let you go with the second question too. Who should be screened for liver cancer and what kind of screening should be done?
Yeah, that's a great question. So the people that should be screened for liver cancer, there's a wide array of people. So the most common or the strongest risk factor for liver cancer is cirrhosis. So people who have cirrhosis should have regular screening done for liver cancer. The most cost-effective way that has been shown in multiple studies is with ultrasound and a tumor marker called an AFP done every 6 months. At times, those tests the ultrasounds may need to be alternated with a CT scan or an MRI. And if there is anything on ultrasound that is suspicious, that would prompt us to do a CT scan or an MRI. Other groups of people that we do tend to screen are those with fatty liver that may have an advanced scar tissue, or those with a viral hepatitis, such as hepatitis B or hepatitis C as well.
Great, thank you. Dr. Khan, how do we take care of our livers? What do we do to keep them healthy?
Well, I think a healthy diet, healthy lifestyle, limiting alcohol. I'd also say if we have high cholesterol, treat that. Diabetes, treat that. Keep the A1C down. Keep the weight down. So I think just really a healthy lifestyle. People, patients often ask me, is there anything special? Supplements? Probably not. Coffee is good. It's funny because I talk to patients about sort of their diets. I ask them about coffee intake and they look at me like, okay, am I supposed to say I don't drink coffee or I do? And I tell them, don't start if you don't drink it because some people don't tolerate it. But we do know that coffee actually helps protect against fatty liver, helps protect against liver cancer, and really other liver diseases as well in terms of progression. So just really healthy lifestyle is the most important thing. If somebody does have a risk factor, if they know that they have a risk factor for hepatitis C, such as maybe having used, intravenous drugs in the past, go get checked out. If somebody has a risk factor for hepatitis B, somebody, from either an endemic area or, has had either sexual contact with somebody with hep B, or is it at risk for some other reason that they think about, go get checked out, because sort of ignoring, the risk doesn't make it go away. And we know now, as you mentioned, 20 years ago, we all know that the treatments for liver cancer were basically either resection or transplant. And now we have so many great therapies that if we can catch cancers early, we could actually have a huge impact on the patient's outcomes.
I'm going to go further and ask you a little bit more about supplements, because everybody seems to think that there's some magical thing out there, and you see it on Amazon, you see it on the milk thistle, for example. Some of those. Is there anything that maybe helps, doesn't help, or we should avoid in particular?
So in terms of supplements, there's really no recommendation for really any supplement. I will say there are some data on things like statins can actually help decrease the risk of developing hepatocellular carcinoma. So if somebody's on a statin, we often are asked, is it okay to take a statin if you have liver disease? In general, yes, it is. And actually, we don't recommend starting a statin to prevent liver cancer, but people that are on statins actually have a decreased risk. Aspirin decreases the risk of liver cancer. We don't say start it because the data are really not strong enough to say, yes, you should take an aspirin because there's some risk, in terms of bleeding and things like that and ulcers. But that does help decrease the risk. Again, I talked about coffee. But really, any supplement that says liver protection or liver health or whatever, usually we're more experienced with seeing sort of liver side effects and liver failure from those things. So anything that says liver in it probably is not a good idea. But again, talk to your doctors. People that are deficient in vitamin A, vitamin D, various vitamins. Nothing wrong with a good multivitamin. Milk thistle has been around for several thousand years. As far as I know, it's a drug or a supplement that's sort of looking for a purpose. It's probably not harmful. No real data that it's helpful. And again, these things can be pretty expensive. So I would say patients should talk to their physicians, their NPs, their PAs, their providers, and talk about it because these things can be pretty expensive. And, oftentimes they're not all that helpful.
Dr.
Right.
Imagawa, we have 3 questions on the Q&A. Would you like me to read them to you?
No, I've got them up here. So the first one
Okay.
was, could you please explain more about the treatment of injecting alcohol into tumors? Sure. So basically what you can do is under CT or ultrasound guidance, you can take a long needle, which is basically the length of a long knitting needle, and under guidance, stick that into a very small, less than 2 centimeter tumor. And if you inject absolute alcohol, which is 100% alcohol, a little bit more, even more stronger than Everclear, you can actually cause the cancer cells to explode, dehydrate, and die. And it's actually a very effective treatment for tumors that are less than 2 centimeters. However, once the tumors get bigger, it's very difficult to deliver appropriate amounts of alcohol into the tumors, because if you put too much, the alcohol is actually readily absorbed into the systemic circulation, and the person can actually get drunk or even worse, have alcohol toxicity. For Dr. Singh, with non-Asian chronic hepatitis B virus, when do you recommend starting HCC surveillance if there are no other concurrent risk factors?
That is a great question. I think the biggest thing for me when I evaluate a patient is knowing when they may have contracted the virus, because we know that the duration of having the virus is going to be what puts you at risk for liver cancer. So if someone develops chronic hepatitis B in adulthood, they might not be as high risk for liver cancer, so I might not opt to screen them. But if people did develop or contract the infection at some time in childhood, then I do often offer HCC screening, liver cancer screening, to the vast majority of my patients, and taking into account if they have any family history of liver cancer or liver decompensation. But it's a conversation that I have with the majority of the patients I see, that may be outside of what our standard guidelines are. But I do feel like in terms of cost effectiveness and patients who may not know what their family history is, that doing, every 6 months screening with an ultrasound may be appropriate.
All right, I'm going to ask the next question to Dr. Khan. What if you've been transplanted already for another reason? What kind of surveillance should you undergo? I'm not sure if they mean liver and other organs or both, but maybe if you can address both.
Yeah, so if somebody has had HCC and they're transplanted, either they knew about it before, or sometimes we find it on the liver when it comes out. We do surveillance afterward based upon really 3 factors. Number one, sort of how much tumor is viable in the liver based on the number of tumors and the largest tumor that shows that it's sort of viable. Number 2, the alpha fetoprotein level, which is the protein that Dr. Singh mentioned that's used for sort of, surveillance for liver cancer. And then the third one is whether or not the cancer is invading blood vessels. And based on those findings, we sort of decide how long we're going to sort of survey the patients after transplant. So the longest we do it, surveillance, is actually 5 years after transplant. The shortest is actually based on recommendations, no surveillance. So it goes from nothing to sort of every basically 6 months for 5 years. So it really depends. For patients who did not have liver cancer, that's a very good question. We do have some patients, say, who, especially people who were transplanted for hepatitis C years ago, who ended up developing cirrhosis before we had good treatments for hep C. And if they have cirrhosis, we do the same sort of surveillance that Dr. Singh talked about, every 6 months, alpha-fetoproteins and ultrasounds, or perhaps other modalities if the ultrasound isn't high quality. If patients develop hepatitis B after transplant, we would probably survey them every 6 months like we would other patients with longstanding hepatitis B, because we know that immunosuppression after transplants, the medicines to help prevent rejection, do somewhat increase the risk of cancers, and we want to make sure somebody, if they're going to develop a cancer, that we find it when it's small.
Great, thank you. Dr. Singh, would you like to add anything to that?
No, I think that's great. Part
All
of my
right,
practice.
next question. We could probably spend the rest of the evening on this. What are the data on the use of Ozempic on liver disease patients? Who wants to take I guess, Dr. Singh, why don't you take the first stab at that one?
Yes, I am happy to do that. So the data with Ozempic, in 2021, the New England Journal of Medicine, there was an article that was published that was a phase 2b trial looking at the use of Ozempic. And so basically they looked at semaglutide, they looked at like the different doses. So they did placebo versus 0.1, 0.2, or 0.4 milligrams of semaglutide. And what they found is that in the 0.4 milligram group, so that's the group of people with the strongest dose of semaglutide, they did see that there was an improvement in the steatohepatitis, which basically means that the inflammation that was associated with the fat was improved over the course of the 52 weeks, I believe. However, the one thing that they wanted to see is that if you had improvement in any scar tissue or damage to the liver, unfortunately, semaglutide did not show that there was an improvement in that scar tissue or fibrosis that can develop as a result of the fat and inflammation. So, in terms of weight loss, it certainly has a benefit. I think anecdotally, and I'm, eager to hear what Dr. Khan says too, but anecdotally, I do see with that weight loss an improvement in liver enzymes often. And I do think that semaglutide, even though not every person with fatty liver disease has diabetes, there is a component of insulin resistance that occurs in the process of fatty liver disease that I do feel that semaglutide most likely addresses that. However, at least the data that we had for those 52 weeks did not show that there was an improvement in that long-term damage.
Dr. Khan.
Yes. Yeah. So what I would say is, there are a lot of drugs coming out, certainly Ozempic-like drugs and other ones. And I think we're going to be talking about combinations of drugs that sort of hit different targets. It's important, I think, in patients with steatotic liver disease, which is what we used to call fatty liver disease, find them before there's a lot of scarring, because the scarring probably, at least with Ozempic, doesn't get better, but it doesn't get worse. So if you can catch somebody with early scarring, get them on a drug, it probably won't get worse. But I think we're going to have actually drugs that are actually going to probably reverse scarring. The problem is with these drugs is, if you stop the drug, the weight comes back and the fat comes back and things progress. So, I think that, patients sort of need to, figure out, do they want to use a drug or perhaps, do some sort of surgery. We're sort of in the era now of sort of bariatric surgery without surgery, where our endoscopy colleagues can actually go and do a sleeve endoscopically, where somebody doesn't even have to stay in the hospital. And if somebody doesn't want to be on a drug long term, the outcomes of that procedure are probably very similar to Ozempic and Ozempic-like drugs. I also want to say, and I tell my patients this all the time, the issue with sort of fatty liver for most people isn't the fatty liver, it's the other manifestations that go along with it. Hypertension, diabetes, cardiovascular disease. And those are the things that actually cause more morbidity and mortality than the fatty liver. So I think it's important to make sure that whatever we're doing for fatty liver, we're actually, helping the other organs as well, because most people with fatty livers will never have progression of their liver disease. Lots of options coming out. Once we cured Hep C, there was a lot of interest by the drug companies in developing treatments for various manifestations of fatty liver and metabolic syndrome.
Yeah,
I
I
also
mean, I think
want to point out one other thing is that we can use these drugs post-transplant. We know that people who gain weight post-transplant have worse outcomes over many years. Worse short-term outcomes, worse sort of moderate-term outcomes, and worse long-term outcomes. So we're using these drugs post-transplant with very few side effects. The major problem is that the gastric emptying is decreased, and so patients may have some sort of upper GI symptoms. Sort of they feel full easily. Things like nausea, vomiting, and we want to make sure that people take their medications, otherwise take good care of themselves and don't get dehydrated because of the medications.
Yeah, I think it's this whole world that's opened up here now of this, like you said, the medical treatment of bariatric surgery in a pill, and all of the, at least for now, all of the beneficial things that seem to be coming with this: improved cardiovascular outcomes, decreasing in hemoglobin A1Cs, and it's absolutely fascinating the progress that's been made.
Yeah, no, it's amazing. It's a new era, and given the fact that somebody had asked me like yesterday, like what percentage of Americans have abnormal liver tests, or what number, and I was sort of thinking about it, and if we think that something like 30-40% or more of patients are obese, or people are obese, and probably half of those patients or more have an abnormal liver test. So we're talking about somewhere in the order of probably close to 100 million people, and those abnormal liver tests are in many cases due to fatty liver. And even though not a lot of those patients or people will go on to develop advanced liver disease, certainly a certain percentage will, and we're talking about millions and millions of people. So this is a really huge opportunity.
So somebody in the chat asked about the gender difference between male and females in developing liver cancer. So I'll go off and say that it's a male predominant in populations. It's anywhere from 60 to 70% male versus 30 to 40%. But I'll then follow that up and ask both of you, what's the role of estrogens, if any, in liver disease and liver cancer?
So I can sort of start with that. So I think that it's really interesting, because if you go back, and David will remember this, many years ago, when we were doing sort of the original chemoembolizations, which was very different than what we're doing now, there was a study showing that tamoxifen, actually, which is an anti-estrogen, had anti-estrogen effects, actually helped decrease the risk of recurrence of liver cancer. But I think as we go on, we sort of realize that estrogen may have a benefit, although in men, probably testosterone, in some cases, testosterone supplementation in some diseases of men actually may decrease the risk. So it's more than just hormones. I think a lot of it is actually, the probably genetic differences between men and women, chromosomal differences that actually are the sort of culprits in terms of risk of liver cancer. But that said, we certainly see more women who are older developing liver cancer with the same diseases than women who are younger. And I think that's disproportionate in terms of men versus women. So I do think there probably is some protective, benefit of estrogen, or maybe something else hormonal that sort of changes, after menopause. So I think the jury's a little bit out on that. So I think the tamoxifen issue is sort of interesting. I think that's been a little bit debunked, because we certainly don't do that anymore. But that was in an era where we really had not much else to offer patients. I'm not sure what Jasleen thinks about it.
Yeah, I mean, the only other comment I guess I would have is that estrogen has been associated with the development of hepatic adenomas. And though the risk of those turning into cancer is very low, like less than 5%, it is kind of interesting to see the converse happen. But that's in a different setting of arising from, an adenoma. But yes,
You must be
interesting.
reading the chat room's mind, because one of the things they asked about were benign tumors and which ones of them should we be concerned about. So do you want to elucidate a little bit more about adenomas for us?
Yeah, absolutely. I led right into that. So, adenoma, so out of the benign liver lesions, most commonly that we see, so we see liver cysts, we see hepatic adenomas, we see focal nodular hyperplasia, and then hemangiomas. So those are kind of the four more common ones. The only ones that we really worry about the most are actually the hepatic adenomas. Once they get to a certain size threshold, which often is around 5 centimeters, they're at risk of not only potentially rupturing, but they also become more at risk of turning into liver cancer. So often at that time, recommendation would be for resection or trying to treat it with different interventional radiology procedures as well. But yeah, hepatic adenomas are really the ones that we worry about the most, depending on their size and their interval growth.
Great, thank you. Dr. Khan, role of genetics and family history in developing liver cancer.
So it's huge. So I actually gave a talk 2 weeks ago on surveillance of HCC, liver cancer, of primary liver cancer, the main one, to a group of gastroenterologists. And I was talking about family history, and I've been working recently on my family tree on Ancestry.com. So I actually put up a picture, not a picture of, a photo of like my family tree going back to like the 1600s. And the reason I did it was most of these people from Europe, I don't know what they may have had. Because, Dr. Singh had talked about, one of the risk factors in terms of, in terms of, surveillance would be actually having a family history. Yes, it's important, but we don't know our family histories. So I do think if we know that there's a family history, yes, the risk is increased. But if we don't know the family history, a lot, especially people who sort of had perinatal transmission, got it during childbirth, a lot of people that came from China, Korea, other countries, where a lot of family may still be there, people don't know their family histories necessarily. So I'm not a huge fan of sort of, if the family history is negative, don't survey for cancer, because I think we don't often know our family histories. But yes, it's very important. For hepatitis B, part of that family history issue may not just be genetics. It might actually be the characteristics of the Hep B that was passed, between mother, children, their children, and vertically and horizontally within these families and communities. So it might not just be the genetics of that person, but the genetics of that virus. But yes, it's very important. If I see a patient, say, a good example is I have a patient with hepatitis B who had a brother who had hepatocellular carcinoma. He otherwise would not have met, quote, criteria for surveillance if you look at sort of the guidelines, although I do think I'm pretty liberal with the guidelines, and I would say I would rather survey somebody with an inexpensive surveillance tool like ultrasound and alpha fetoprotein, even though it might not be, quote, cost effective. But when the patient told me, number one, I have a family history of hepatocellular carcinoma, that made me do the surveillance, very, very early, because I was worried about it. We see that also in colorectal cancer. We see if somebody had, especially or breast cancer, somebody with a family member with an early cancer, we worry more about them, acquiring those cancers earlier. So yes, family history is very important, but it might not just be the genetics. It might be other, environmental factors as well. Another example is patients from Africa. Patients from Africa with Hep B should start surveillance for liver cancer at age 20. A lot of that is because of aflatoxin, which we find on corn, we find on peanuts, and all sorts of produce and other things, is a cofactor for liver cancer besides hepatitis B. And so it might not just be the genetics, but also the environmental factors that made that person predisposed, just because of their environment, their community. So.
Next question, we'll switch gears a little. Drugs currently being studied or in the pipeline to reduce that fibrosis that you guys talked about in the non-alcoholic fatty liver disease?
I can take a stab at that one. So there's a very exciting drug that whose phase 3 results were just published, or sorry, discussed at EASL, which is the European Association for the Study of the Liver Disease. And so it's called resmetirom. It's a thyroid hormone receptor beta agonist. It was basically compared to placebo. So they looked at 2 different factors. They looked at improvement in the steatohepatitis, or that inflammation, without worsening of scar tissue, and they looked at improvement or reduction of that fibrosis or scar tissue without worsening of the inflammation. And that drug in phase 3 trial actually met both endpoints, and it actually also lowered LDL, which is considered one of the bad cholesterols. So in terms of reduction or improvement of fibrosis, that one medication is something that everybody is very, very excited about. So there's been a new drug application that was submitted to the FDA like many months ago. They will be hearing by March of 2024 whether the drug will be improved or approved. I mean, when we're talking about improvement of steatohepatitis and of fibrosis, we're talking about on the order of like 25 to 26%. So it's not like, not everybody who's on it is going to see those results, but it's better than anything that we have. So that was a long-winded answer, but that is.
No, it's a great answer. I was fortunate enough to be in Vienna for EASL and went to that talk, and the excitement generated around that by everybody was really, really one of the rare things that you see at an international meeting. But it's we've had years and years of trying to make things get that fibrosis thing to reverse, and this at least gives us a window of hope that something might happen. Dr. Khan?
No, I agree. And a lot of other drugs as well. And I think combinations are going to be what we're going to be doing. And the other thing is, sort of like cancer treatment nowadays, I remember going to meetings, 10 or 15 years ago, and they said, in general, we're going to treat not the name of the cancer, but the characteristics of the cancer. So we have ovarian cancers that we treat like liver cancers, that we treat like lung cancers. And I think we're going to be doing the same thing with fatty liver, looking at the characteristics of that patient and actually targeting therapy toward that specific patient, what we would say personalized medicine. So I think it's really exciting. And again, last I looked, there were about 50 different, drugs that are sort of in the pipelines, and a lot of them sort of disappear during the, phase 1, phase 2 studies, even later studies. And it's going to be harder and harder to actually, bring on new medications, because you're going to have to at least show non-inferiority, meaning it's not worse than something else. And, hopefully that it's better than something else. But I think a lot of the studies are going to be combinations of these different drugs. So I think it's a very exciting time.
Great. So I'm going to give this final question, and hopefully we can generate a little bit of controversy with this one. This is a great question, and I'm going to just read it. I'm going to quote it since it's here. We are told that the ultimate treatment for liver cancer is liver transplantation. What is your opinion on small, single HCC without decompensation? Do you recommend liver transplant evaluation even after local regional therapy? I'm going to let Dr. Singh go first, and maybe that's her disadvantage because it's going to give Dr. Khan time to think about it. But Dr. Singh, your thoughts?
I think this would be a great debate topic, to be completely honest. So, I think the textbook answer would be that someone who has cirrhosis, who has, a T2 lesion or greater within Milan, should be evaluated for liver transplant, and should have bridge to transplant with local regional treatment. That being said, I think that our IR procedures have advanced to such a degree that what we are seeing, at least here at UCLA, is that often these patients have local regional treatment, like ablation in particular, and they might not have recurrence on the order of years. And the question then becomes, do they still need a liver transplant? And that's where it gets dicey. You know, patients who have recurrence after local regional, either, recurrence in the same site or elsewhere, those for sure, those patients need to be transplanted. But the ones that who do not have recurrence, it brings up a very interesting question that I would like to hear from Dr. Khan about.
Dr. Khan.
Yeah,
Point
so
counterpoint.
certainly years ago, liver cancer was a surgical disease. It was either transplant or resection. I would say for a well-compensated patient with a small lesion, nowadays there are so many potential options. The problem with liver cancer is that, the soil, the liver is the soil, and the soil is sort of foul soil that is prone to growing cancer. So you cut out a cancer, it may grow back someplace else. You burn it, you ablate it, you treat it with medications, whatever. We used to talk about the risk of, patients after doing some sort of ablation of a cancer and then it comes back so big you can't transplant it. I think those days are kind of gone. We have so many different options for the cancers that I think in a very, very well compensated patient, I think the issue was really resection versus some sort of local therapy. And then in somebody who's not compensated, I think transplant. So if somebody's liver isn't working well, they're not going to do well, whether you treat the cancer or not, their liver's still not going to do well. So I think that kind of person should be transplanted. I think for the early cancer and somebody who is easily treatable, a good option might be resection and then some sort of other therapy. We're doing some studies at USC looking at resection or some sort of ablative therapy plus immune therapy that Dr. Imagawa was talking about, like the PD-L1s, and the combination immunotherapies. So I think as long as we follow patients closely after we treat them, you almost can't go wrong. So I've had many patients where I say, I think you should have a transplant. They say no. And then, 10 years later, we're still talking about it. I have a couple of our transplant coordinators who work with our liver transplant patients on this Zoom right now. And, they can, I think both tell you, we've had many patients say, I don't want a transplant. And years later, we're still talking about it. So I think we have to involve the patient in that discussion. So I think we're at a great time for liver cancer. The idea is if you treat somebody, follow closely. We have a great group of oncologists we work with. We have a tumor board every couple of weeks. We go through all the patients, and patients aren't going to sort of fall off if we follow them closely. So we really include them in that decision. So.
Yeah, and I think that's the most important point is what does the patient want? And two, what long-term close follow-up. And then again, I think this is all complicated by the IMbrave 50 study that, has been recently published showing that the same combination for the unresectables decreased high-risk recurrences by 25-30%. So do you really want to necessarily transplant somebody and put them on immunosuppression when you're talking about maybe 6, 7, 8 years before there's a recurrence as you kick that curve out? And that's probably going to get better as these other studies go forward, because there's no reason to believe that that's the optimum combination therapy. So like I said, it's so exciting to be in a field where you're too young to appreciate this, Dr. Singh, but Dr. Khan and I started with this when we didn't even know it was Hep C. It was non-A, non-B. We didn't even know what it was. Now we have a cure for it. We had no systemic chemotherapy to treat liver cancer with them. As Dr. Khan said, it was a surgical disease. You got a transplant, you got a resection, or you died of liver cancer. And I think a lot of this is, again, with the clinical trials, the funding, the things that Liver Health Foundation, American Liver Foundation provide, the grants that are out there, and the patients who put their faith in the doctors to go on clinical trials to advance these things. We wouldn't get these results if people didn't have faith that medicine was actually moving forward. So at this point, I think we've kind of run our time. I'd like to thank our panelists. I'd like to thank Farah for setting all of this up, but since Farah's the boss, she ultimately gets the final word. So Farah, I'm going to turn this back to you.
No, I'm the boss of nobody. But really, thank you. This was a fantastic roundtable. I feel we could go on for another hour and still have more questions to ask you. I hope everybody enjoyed the webinar and received the new and important information. I know that for sure I did. So at this point, I want to thank Dr. Imagawa for your excellent presentation and emceeing our roundtable. Thank you so much. We are sorry Dr. Bayani wasn't here, but thank you to Dr. Khan, and also congratulations again on your award for excellence in healthcare.
Thank you.
Yes, thank you. I'm sorry, I kind of blanked out. Thank you. Thank you, Dr. Jocelyn Singh, for coming to our webinar. We enjoyed it. We like to talk with you more about everything you're doing as working with the patients. So every one of you are very important to us, and this was a great webinar. Now to just tell you just about one important webinar that's coming. We are hosting an exclusive webinar just for medical professionals, doctors, nurses, fellows, residents. The topic is LALD, and the speakers are Dr. Gupta and Dr. Raf. This is a webinar full of new information about LALD and new treatments that's coming up. And as mentioned, it's only for medical professionals. If you would like to attend that webinar, please give me an email on info@liverhealthfoundations.org. Liver Health Foundation is on all social media sites. We announce our events and news and programs on our website and social media. Please visit us. Thank you to our panelists. Thank you, Dr. Imagawa, and thank you for joining us for this very important webinar on liver cancer.